I'm Caleb Furnas, welcoming you to Raise the Line with Osmosis from Elsevier, an ongoing exploration about how to improve health and healthcare. Today, our ongoing global tour of medical education stops in the Republic of Ireland by way of a conversation with the head of school in Trinity College Dublin School of Medicine, Dr. Colin Doherty. Dr. Doherty is also the Ellen Mason Bates Chair in Epileptology at the school. His training as a neurologist included stops at St. Vincent's and Beaumont Hospitals in Dublin, and later at the Partners Neurology Residency Program in the Harvard University system, where he also completed fellowships in epilepsy and cognition. Dr. Doherty has clinical and research interests in the areas of brain imaging, clinical epileptology, traumatic brain injury, and digital health. Thank you so much for joining us today.
Delighted to be here, Caleb.
I'd like to start with learning more about you and what first got you interested in medicine and in particular neurology.
Well, thank you for that question. Who doesn't want to talk about themselves like this? But actually, when you reflect on it, sometimes it's hard to remember. I remember when I was in high school in Ireland, wanting to be a medical student. I actually hadn't thought beyond that. There was something about being a medical student that really attracted me, the learning that involved going to medical school. Soon after entering medical school, I had started off wanting to be a surgeon. I got rid of that notion very quickly. And then I think I began to really become interested in human behavior. And I think I was naturally drawn to psychiatry as a career. Still, even though I didn't do that, I still would consider myself a person very interested in psychiatry as a mode of inquiry into human behavior. And I think I've probably more broadly considered myself to be a neuropsychiatrist because so much of what I do involves things that psychiatrists also think about. And the division between psychiatry and neurology, of course, is very artificial. And one of our mentors in Mass General when I was there used to say, the brain, a single organ divided by two specialties, which, doesn't make sense. And around the world, there are lots of divisions in psychiatry and neurology, which really just don't make any sense. And so much so, it's just a strong sense that I have, it needs to be changed. We're actually creating a new division in the medical school under our new governance structure. And it's going to be called a Mind, Brain and Aging Institute, which is trying to sort of dissolve that. It will have psychiatrists and neurologists and aging experts involved. We're trying to do away with the barriers that exist. So I suppose, yes, I'm broadly speaking a student of human behavior has always interested me. And that's where I find myself.
And why the interest in epilepsy?
Well, yeah, so that's, I think if you asked anybody how they became a subspecialist, what happens is you meet a mentor. I think this is probably true for many people. So you're in a broad field of interest. I was in the neurology field. And then you meet somebody who says, listen, I've got this project that I'd like you to do. And suddenly you find that your expertise is building in an area. And it just makes all sorts of sense that you would continue to do that. And depending on how inspirational that mentor was. And my mentor was a guy called Hugh Staunton, who was the father of epileptology in Ireland. He's dead now. He died in 2011. He got me into it. He sort of asked me to start measuring brains using computer-aided technology at the time. This is the 1990s. It was very rudimentary, but measuring brain volumes in patients with epilepsy. And all of a sudden, I had some expertise. And before you know it, I'm offered a fellowship. And then suddenly I'm an epileptologist. But that's never stopped me from being interested in all broader other aspects of neurology. And I have a particular interest in cognition, which of course is affected in people with epilepsy, but also dementia and brain injury. So that's how I developed my subspecial interest.
In your time studying epilepsy, what are some of the most significant advances that you've seen in the field? And what makes you most excited?
Yeah, that's a great question. I think the media answer to that question, I could talk about what I personally am interested in, but I think there is a correct answer to this, which is kind of remarkable. And in my lifetime, since I began studying this, epilepsy was started off as a disease of the brain that you acquired from a number of environmental insults between head injuries, brain infections, meningitis, encephalitis, brain injury, trauma, etc., etc. And yes, there was a small number of epilepsies were considered to be genetic and that they affected probably 15, 20% of people. And the rest of it was some, cause, which was in the environment. And in my lifetime, that has completely switched to the point where now we consider epilepsy largely to be a genetic disease, of which there are some environmental triggers and things which may make it suddenly become to the surface. But essentially, it's a genetic disease. And that's a kind of remarkable change in my lifetime. I think at a more personal level, I do think that I become interested in kind of two aspects of epilepsy care, which I think don't get sufficient cover. And one of them is the idea that seizure control, stopping seizures, is not the only important thing. It's not the only thing that people with epilepsy want from you, right? It's bad enough that you have seizures and you lose awareness intermittently, several times per month, several times per week, several times per year, and that you can't drive and you can't study. It's not enough. That's bad enough. But the time in between where you're trying to live your life and have the aspirations for a normal life can be severely affected by perceptions that other people have about epilepsy. So the stigma that epilepsy is affected, and somebody like me would have a large role in trying to deconstruct stigma. And also the fact that like the medications themselves, can cause significant side effects. And getting the balance right between somebody suffering daily side effects, even though they're not having seizures, versus somebody who might have an intermittent seizure but still feel well in between times. That's a conversation sometimes doesn't happen. The assumption with most people is, just get rid of the seizures, doc. I don't want to hear anything else. Just get rid of them. And in fact, what I know now is that that's not the requirement. The requirement is for, as full a life as possible. And so you're sometimes mediating that difference. But you look at the therapies, you look at the literature, it's all about seizure control. That's the outcomes. When it comes to clinical trials, how many seizures will stop? So I think that's an interest of mine. The other area that I'm interested in personally is this area of what are called non-epileptic seizures, which really are not epileptic. So in some senses, it's not part of epilepsy. It's part of this broader designation, what we call functional neurological disorders. And yet epileptologists end up seeing these people because the inquiry is always, do they have epilepsy? And when you realize they don't and they have something else. And then FND, or functional neurological disorder, is this group of disorders that's really only been properly classified in the last decade or so. And there's some significant expertise in the world, but actually still relatively modest number of people understand this. Probably the biggest expert is a guy called John Stone, who works in Edinburgh. And he's really brought the community together around the nomenclature. And I don't know, Caleb, for instance, do you even know that term, functional neurological disorder? It's amazing to me because I'll make a very, very dramatic assertion now, right? So functional neurological disorder is the reason that neurology exists as a specialty at all. And yet you've never heard of it. Mm-hmm. It's probably the second most common reason to get referred to an outpatient clinic to see a neurologist. And yet you've never heard of it. Mm-hmm. That's a kind of fascinating phenomenon. And why have you not heard of it? You've not heard of it because we don't have any biomarkers. We don't have any treatments. None of the scans show anything. It's heavily linked. It used to be heavily linked to psychological disorder. So it was called conversion. There are various designations within the DSM and psychiatry for functional neurological disorders. And yet it's considered a kind of a subspecialty interest within psychiatry. And yet it's absolutely the most common thing. If you go back to the man who came up with the term neurology, which was Thomas Willis, who was the Sedleyan professor of natural philosophy in Oxford in the 17th century. And he defined the term neurology. So it became a specialty really in the 17th century. And his interest was trying to understand what was then called hysteria, behaviors which arose often under stressful situations where patients collapsed or fell to the ground or grabbed their throats where they couldn't swallow or couldn't walk or became paralyzed suddenly. And throughout history, this phenomenon has been of fascination to famous neurologists. The most famous neurologist in history is probably Jean-Martin Charcot, who worked in the Salpêtrière in Paris. And Charcot was absolutely fascinated by hysteria. Anyway, he found the lesions underlying multiple sclerosis in the brain. And so, quite rightly, that's what he should be known for. But in fact, Charcot was known for having a lifelong fascination with what was then called hysteria, which we now call functional neurological disorder. And we've made no progress. We have very few centers in the world. When you think about the number of centers we have, the centers for epilepsy, centers for MS, centers for oncology, centers for surgery, we have no known centres in the world, apart from maybe the one in Edinburgh that John Stone runs. And I think there is one also in Mass General. But as a subspecialty, where will I go to get my functional neurological disorder treated? There are none. There are no clinical trials. There are no treatments. Absolutely fascinating. 400 years of the history of neurology, which began, I think, plausibly by people being interested in what this thing was.
Right.
And yet we've made no progress. By the way, they're my particular interest. I've become interested in that as a sort of ancillary thing, because epileptologists see these people because they come in, they lose consciousness, they collapse on the ground, they shake, they look like they're having convulsions, but yet it's not due to this kind of underlying electrical abnormality. It's due to something else. So anyway, I've a bit long-winded answer, but that's where I am.
No, that's fantastic. And so many things in medical science like take these sort of circuitous paths and become these fields almost by historical accident as much as anything else. So it's fascinating. I mean, I'm curious, like, as a layperson, I keep seeing things about ketogenic diets for epilepsy. Do you have any view on that? Is that something that is, making inroads?
We have in my department, in my division of epilepsy in the hospital I work in Dublin, which is St. James's Hospital, which is the largest hospital in the state. We have the only adult ketogenic diet program. So the pediatric hospitals use it a lot. So pediatricians have been using ketogenic diet for 100 years. The transition to adults using it has only been relatively recent. And a lot of this is because kids living into adulthood and having to have an adult service. So yes, no, I think it's a completely underutilized treatment. So if you look at the data supports the use of dietary treatments, including the ketogenic, although there are other forms, less severe forms of treatment. I can go into that in detail if you want, but just for argument's sake, I mean, if you're eating a diet of only protein and fat and no carbohydrate, which is pretty much what the ketogenic diet is like for the youngest kids, it's practically inedible and impossible to continue for life on that. So you've got to find some ways to modify it. And there are various modifications, including what's called the modified Atkins diet, which a lot of people will know. And then there are modifications of the ketogenic diet, including a really modest one called the low glycemic index diet. Anyway, dietary therapies as a group have about 1/3 efficacy for epilepsy. Now that sounds, that's not great. But remember, these are all being used in people who have failed all the medications. So they're already in a very highly refractory group of patients for whom nothing medication-wise has worked sufficiently. And so when you take that group and you get 1/3 of them better with the ketogenic diet, suddenly it becomes a very, very significant therapy. So I do believe that this is a very underutilized therapy, particularly in adults. And yes, we're big fans of it here. And we do a lot of research in the area. And any chance I get, I will talk about the diet. I mean, for me, the whole notion, by the way, in the broader health sphere that food is medicine is very, very important, under-recognized fact. And I am embarrassed to say, like a lot of my colleagues across the world, that we do not do in any way enough teaching in the area of dietary therapy or diet per se as a route to health.
Yeah, no, that's a common refrain we hear in the States too, given that medical school is mostly focused on disease and sort of sick care, you sort of hear this a lot. But so getting back to your role, as a teacher and as an educator, I understand that you have a curricular reform underway. And as part of the thinking around that, Trinity College Dublin recently held a workshop on the medical school of the future. What did you draw from that workshop and how might it inform your revised curriculum?
Yeah, so it's been my term here as head of school began 2 years ago, and it's usually a 6-year term. Trinity has a very quaint way of doing this. You get voted in. It's it's a beauty contest. They don't look for, administrative flair or, experience in administration. So I've been in this job for 2 years. And I think, the medical school's been here since 1711. So it's more than 300 years old. It's going to be here well after I'm gone. So in terms of, the capacity to have any legacy of change, I think the changing the curriculum now is the most likely area that one could stamp one's authority or legacy on. And it's been a really interesting process. In Ireland, unlike the US, we have a great degree of autonomy in terms of medical education. In other words, the medical council, which is the regulating body, is really only an advisory body to Irish medical schools. They advise and they give out the rate, but they don't tell you what you need to teach. We have metrics around the number of hours of teaching they have to get, but so long as we put in the assessment, a proper assessment process and a proper teaching program, we can if we can make the argument, then, in fact, I would say that the real block to a radical change in how we train doctors in Ireland is more the faculty itself, because, doctors are relatively conservative people. That's one of the benefits of doctors, and one of the things that drives me crazy. They don't jump on the bandwagon of new therapies immediately. They're likely to think hard about changes. And so our issue is not with the medical council or a regulating body. In the US, things like the USMLE, the steps they have to take, if there isn't a question on the USMLE, then there's no point.
Is it really science? Yeah.
Because you just have to pass those things. So I think we're ahead of the curve in that regard. So we were taking on some of these big mega trends around climate change and health, around digitization and AI, and data and big data analytics. And so that's kind of really interesting to be able to put those in. Of course, the first question everybody asks is, well, what are you taking out? Because our medical students are busy from the minute they walk in the door to the minute they leave. And so there's a little bit of downward pressure on some of the older traditional basic sciences, like we're reducing our biochemistry, we're reducing some of our physiology, and that's not popular with certain people. So the negotiation is much more local than national about that. But look, I think we're coming to a nice balance in those things. And so there's I would say, a core of medical training that's probably been there, from the year dot. I was speaking to a 94-year-old graduate of Trinity College. He graduated in 1964 and he was 36 when he graduated. So he was already a late learner. And he was able to send me an essay he wrote for a debate that was being had in the medical school at the time about the curriculum. And he says, almost line for line, you could have written it last year. There's far too much biochemistry on the...
Right.
So anyway, we have made some inroads there, and that's been really interesting. And part of this was, I didn't want to be too transactional, just take out biochemistry, put in AI, this sort of stuff. I wanted it to be a more creative thing. So we set up this idea of a scenario analysis, a way day, where we brought not just people from the school, but also people from external. We had the head of the medical council there. We had a couple of external people from government there. And then we had medical students. So we did this creative workshop. And it was based around, we took 4 scenarios about how the world might be using just simply the question of digital and environment. And so we said, look, if we had a digital world, and it was kind of a dystopian digital world where we're all just walking around with VR headphones on us, and then the dystopian environmental catastrophe where the world is just no longer livable in, versus one that might be much more optimistic, a much more optimistic view of how digital and AI and the environment is, And we asked everyone to consider what normal life will be like and what the training of a medical student would need to be. And very gratifyingly, by the time the end of the conference came, the emphasis on humanity, on patient-centeredness, on systems thinking, the students themselves presented the work from the groups, and it was really gratifying that central to the future of our workforce is still humanity, which, I think if it was robots, I think we'd all have been throwing ourselves out of the windows. But the central thing is not robots. The central thing is still the humanity of the healthcare worker, and so that was gratifying. So yeah, so look, we're still in the middle of this. I myself have been pushing, for some issues around the ethos of our outcomes. What kind of ethos must somebody have when they come? And I've been pushing for, words that people are uncomfortable with. Things like, I think love is a word which should be central to what a medical student should come out of their training with, And when I've talked to people who are not medics, and you're not a medic, Caleb, I think you didn't, no. They get it. Oh yeah, that makes sense. Yeah, they have no issue about that. But actually a lot of resistance within the medical profession to introducing the notion of love as an outcome measure. And so we've been challenging ourselves all the way through this process. And I think it's going to be really good. Not the end of what we need to be doing in medical curricular reform, but certainly one that I think we're going to make progress, and excited to see what that looks like. The first tranche of the new curriculum should roll out at September 25, I think.
We have many students and early career health professionals in our audience. What's your advice to them about meeting the challenges of this moment, given all the challenges that you describe and given the changing landscape of medical education?
Yeah, I'm sure there's a very wise, broad piece of advice there, but I can't think of one. Let me just say something very specific. And I think this is really important because I've been aware of course, the growth and the interest of AI and artificial intelligence into medicine and the potential benefits for that. What I think is missing from that debate is the issue of what I call AI safety. I think there's something that we as clinicians and as citizens, by the way, need to start, because the only block to robots essentially taking over the work clinicians do, the only block to that, there's no technological block, right? Now, what I mean by that is, Caleb, the technology already exists now. The only difference is that there is still a little bit for the technology to do around things like empathy and intimacy. There's still a little bit of a battle around those things. Can these systems really do the empathy and the intimacy that normal clinicians do? And some of the optimists say, oh yeah, they're not there yet. I don't know about that. Some of the data around mental health treatment by bots is suggesting that these guys have broken through the empathy barrier. So let's say, for argument's sake, without being alarmist, right? The likelihood is for a lot of conditions, particularly ones that don't involve interventions like, surgery, etc., for managing chronic conditions, say, we will be replaced. We're going to be replaced. That's basically it. So the question now is, what kind of society do we want to live in the future? And remember, there's an asymmetrical war. The tech companies are pouring billions into this, and nobody's pouring any money into the AI safety agenda. Why would they? Anything that might put the block on the uptake of AI, sure, that's just anti-competitive. That's just anti-capitalist, right? But we really need to, as healthcare professionals, and for the younger guys who are on listening to this, we really need to put the brake on this. And the only two things that will stop healthcare being replaced by a whole load of very empathic, very intimate, not dangerous robots. They're not going to be going around killing us on the streets, but they're going to take our jobs, right? They're going to do the job we have done, and they're probably going to be better, and they're probably going to be safer. Yeah. The only thing that would stop that is some sort of regulatory framework that creates a symbiosis between AI and human that still has the human at the center of this human relationship at the center. Yes, by all means, let the AI help us with safety. Let them help us with making the right choices for treatment, but don't intercede them between us and the patient. And that is, nobody is doing that. There's no money in it. Nobody wants to support it. You might get some government money for it, but you're not going to get the tech companies supporting it. So it's up to us to come together as a community of people and make the future of healthcare what we want it to be. And look, there may be people out there saying, I actually, my image of this in the future is, it might be horrific now to think that you would go into your doctor's room and it's an AI robot. That, Dr. Doherty is busy today. I'm going to be your doctor. People would run out of the room. But in 10 years' time, the opposite might happen. You would walk into and if it's only you, they'll go, where's your robot? I don't trust you to know what to do. And they will run out of the room the opposite direction. So don't let that happen. I'm thinking, I'll be gone. I'll be retired in 6 or 7 years. It's up to you to save the world in relation to the healthcare environment that you want to see.
No easy task, I'm sure, but definitely something to keep an eye on. Well, with that, thank you very much, Dr. Doherty, for being with us today.
Not at all, Caleb. I enjoyed it.
I'm Caleb Furnas. Thanks for checking out today's show. Remember to do your part to raise the line and strengthen the healthcare system. We're all in this together.
If you like this podcast, please share it on your social channels. You can also subscribe to the series and check out all of our episodes at osmosis.org/raisethelines podcast.